be talking about screening for type 1 diabetes, monitoring the people, so who do we screen, monitoring those people, and of course it's a very exciting time. You know, our chairman has introduced the fact that we thought we didn't have a way of preventing or delaying type 1 diabetes, but now we have, and I'll be talking a little bit about the new treatment that we have at the end, and I think that's going to be transforming the way we look at type 1 diabetes. So here are my complex. So as I say, I'm going to be talking about screening, spend most of the time talking about screening and monitoring of this disease. And how do we monitor people? And there's now some international consensus guideline that I'll talk you through on how to do this. So I'm going to begin by reminding you that type 1 diabetes is an autoimmune disease. We always treat it as a metabolic disease with insulin and this and this, but it's not. It's an autoimmune disease, and we never treat it as an autoimmune disease. Rheumatoid arthritis, multiple sclerosis, even psoriasis, we treat with drugs for the immune system. We don't do it in type 1 diabetes. But when we're trying to detect it early, we need to use the immune system to detect it early. And we do it by detecting islet antibodies. And these are autoantibodies to proteins on the beta cells in the islets of Langerhans. I should just point out that the disease is not caused by these antibodies. It's actually caused by T cells. It's cellular destruction. But these are much easier to measure, so this is what we use in the blood, and we can detect the disease early. It's worked very well for us. So it's important, probably worth you remembering that there are 4 different flavors, if you like, of these antibodies. There are probably many more, but these are the 4 we know very well. Anti-insulin, anti-IA2, GAD you may be familiar with, and ZNT8. And these are all proteins that are present on the beta cell. We used to talk about anti-islet cell antibodies, or ICA, which was really when we just took serum and we put it on some rat pancreas. We didn't know what it was measuring. But now we don't really want to use this anymore. We want to be more specific. And you'll see in a moment why that's important, because we need to know the number of different antibodies, not just that they're present. So I think you've done a little introduction as to why we would want to pick this up. And one of the ones you showed so well was the high rates of ketoacidosis here in Saudi Arabia. So if we detect people early and we monitor them, we can substantially reduce this rate of DKA. Maybe often almost make it 0. And if you pick people up early, it gives you time to psychologically adjust. At the moment, when a new child is diagnosed with type 1 diabetes, or an adult, the first place they go is not the outpatient clinic, not your surgery, it's the emergency room. That's their first experience of diabetes. It's a terrible experience. Sometimes they're in intensive care as well, or high dependency to treat their DKA. They seem to have a very short period beforehand, just a few weeks of being unwell, and nobody understands what's going on, they're losing weight, etc. And then bang, they're very, very sick. So we can, instead of doing that, we can have time for them to adjust to the diagnosis, opportunity to provide education and counseling in an outpatient setting in a much more relaxed way about what's going to happen, maybe prepare them for monitoring blood sugars and for preparing them for insulin skills. We can avoid them coming into hospital at all, and I think this should be our aim, that they never need to come into hospital. And of course, behind this, I'll be able to say at the end, we're now in the era of being able to not only detect them, but also to delay the time before they need insulin. So I'm going to talk about who, when, and what. Who would we screen, when would we screen them, and what are we going to screen them with? All 3 are quite tricky, so listen up, as it were. So who are the people at risk, and what about people without risk factors? Let's start with the who. So the easiest one is relatives of people with type 1 diabetes, right? So if you have type 1 diabetes, you have a first degree relative, they have a 1 in 30 risk. So about a 3% risk of developing type 1 diabetes. It's quite low, you would say. So I say to parents who have type 1 diabetes that maybe you need to have 30 children in order to have someone with type 1 diabetes. Actually, I noticed that colleagues here in Saudi Arabia are telling me that it's more frequent than that. They're seeing often 2 or 3 children in the same family. That's quite rare in the UK. So I think you have a higher rate than probably 1 in 30. Thank you. So in the general population, however, it's much lower. It's about 1 in 300. So we already know that this group are a good group to target because they have at least a 10 times increased rate of type 1 diabetes. And they also know what's going to happen. When we have a discussion, we'll talk to you a little bit about what's the difference between families that they want to be monitored versus the general population. It's a bit controversial in families, but they know what's coming. So there are certain people with certain genetic variants, and we can actually screen for genetic risk. We don't do it routinely. And another group that's worth bearing in mind is if they have other autoimmune diseases, such as thyroid disease, for example, is strongly associated, autoimmune thyroid disease. So if you have one autoimmune disease, autoimmune thyroid disease, celiac disease is strongly associated, then this is a clue that they could be at risk for type 1 diabetes. So this gives you an idea of the relative risk. Notice that this is not a linear scale, this is a log scale, so be a little bit careful here. So in the background population, this is 0.3%. So as I said, about 1 in 300 is the background rate in the population. So that would mean in the background population, you have to screen 300 people to find one. But when you have a first degree relative, meaning either a brother or sister, or a mother or father, then it's closer to 3%, and maybe, as you mentioned, a little bit higher in Saudi Arabia. Interestingly, can you notice the mother is lower than the father? And there's good evidence for that actually if your mother has type 1 diabetes, your chance of getting diabetes is less. It seems to protect you, but only, and we've done some research around this, it's only if the mother had their diabetes when you were in utero. If the mother was diagnosed